So next, we have Dr. Prabhu Shanker, and he'll be speaking on a very tricky scenario. Like you have a PCR with nearly the entire nucleus there. So what to do? So it can go down, whatever. I mean, what should be the plan of action in those cases? Prabhu.
Thanks, Rini. I think the title is PCR with the entire nucleus in the back. So there's no choice now. So you have only two choices. You have to take a decision on table. You know there's a PC end there. Either the rexus margin is extended or the rexus margin is toward the edge. You don't know whether it's continuous behind. So you have two choices. Either go ahead with the phaco. If you have a VR surgeon backup, then it's very safe. You can proceed even if it drops, no problem. If you don't have a VR backup and you need to refer a patient to a surgeon or a different hospital, that's the time you end up in problem. So either you do a phaco continue or you proceed with SICS. So I'll just show basically two videos and see one had a complication, one went without a complication. Okay, this video is for So what it does, I think the only thing here is it's quite a mature cataracts, intumescent. The only problem now is the rexus is pretty small, okay? So whenever you chop, it's roughly around 4 millimeters. It's going to extend somewhere because it has to extend somewhere because the rexus is very small. So surgeon is doing a horizontal chop now. So now we can just keep watching the left temporal side of the rexus. You can see the snap sign. Suddenly it snapped, the rexus margin snapped. That means, see, the rexus is extended, the snap sign was there. That means the PCR is extended posteriorly. Now the question now whether surgeon needs to convert now or not, but surgeon is pretty confident. He knows that he can manage it. You can see the nucleus is tilting down towards temporal side, is tilting down. That means PCR is extended posteriorly is an indirect sign. But surgeon is still adamant that he don't want to bring the nucleus up. So what I would have done differently here is extended the rexus and brought the entire nucleus up and put the IOL behind for the scaffold and proceeded the phaco. But somehow I think the surgeon was lucky, his was day maybe. So nucleus didn't drop in spite of doing all these maneuvers with the smaller rexus. The nucleus still didn't drop and still is able to manage. And only when the last piece is there, so he takes the adequate precaution that I think he puts a visco now, stabilizes the chamber. So whenever you have a PCR, never come out immediately. Just stop, be in the irrigation mode, make sure you don't decompress the eye, put sodium hyaluronate preferably. You can see a large rexus there, surprising that the nucleus didn't go down. So now we're just putting, stabilizing the anterior chamber with viscoelastics so that you don't want a lot of vitreous to come out. So at this stage, you have no choice. You have to do anterior vitrectomy, and I would always prefer to go in for a three-piece foldable lens, the sulcus. And okay, anyway, since the rexus is margin extended, difficult to do optic capture. But I would have always placed a three-piece IOL on sulcus. But the surgeon has done a different thing. He did the anterior vitrectomy now. He's doing a bimanual anterior vitrectomy. That's the way to go actually. So never extend the section and undo the vitrectomy. It always vitrectomy has to be in a closed chamber. She's extended posteriorly, made a SSCs at this stage now, put the IOL in the sulcus PMMA lens, strained with triamcinolone, and he got away with the surgery without any major issues. So next video is one of my videos. Yeah, now here you can see it's a posterior polar cataract. The capsule is already opened up. So after doing a rexus, even there's another choice. This is very soft cataract. It's very difficult to do SACs in these cases. Without hydrodissection, you cannot bring the nucleus out of the back. The way to go is a phaco. Either you can do a phaco aspiration or phacoemulsification. So I'm very slow now because I know the capsule is down. So even if it drops, I'll only have to remove it because I do both. So I'm very cautious. The only big advantage is this patient has had a long-standing, you can see the PCR, big PCR behind now. So this, why nothing is happening is, this patient had a posterior polar cataract for quite some time and it's opened up. So all the anterior hyaloid face has got fibrous now. So there's PCR is remaining the same, is not extended. So it's very easy to maneuver at this stage. You can see the posterior plaque coming out. So make sure you don't use very high parameters. And always, it's like any posterior polar cataract, the subincisional nuclear fragment is the last one, it's very difficult to remove it. In this case, you cannot do any other maneuvers because even if you put visco or whatever maneuver is there, they're very difficult because it's going to extend the excess. So very slowly I'm managing it with very minimal phaco parameters. So once when you come towards the last segment or either ready to bring out the phaco probe, make sure you fill the anterior chamber with viscoelastics, preferably sodium hyaluronate, so that it doesn't cause any vitreous turbidity post-operatively. So you can just see, you can see a nice vertical large rexus. So now I'm not emulsify the last piece. So I'm just stabilizing the eye now. So with the left hand I'm putting sodium hyaluronate. So stabilizing the anterior chamber well. The bag is also filled. So in the last piece one, it's very easy now. So in this stage, you have two options, whether you want to put the IOL in the sulcus and do optic capture, that's a good option. But I've decided to go in with IOL in the bag now. So I gently manipulate the lens inside the bag. So I managed to put the IOL in the bag. So it's pretty stable now. So IOL is also stable, no issues. So surgery went on smoothly. So you have two choices. So once you know there's a PCR, you have to make a decision whether you want to convert to SICs or complete phaco. Thank you.
Thank you, Prabhu. We'll have more discussions after the end of all the